Thank you, moderator, for the opportunity to present at SAGES. My name is Wanda, a third-year general surgery resident at University Hospital's Cleveland Medical Center. Today, I'm going to talk about bariatric efficiency at an academic tertiary care center. I have no disclosures. The objective of our study was to understand how variable OR staff and teaching affects efficiency of bariatric surgeries at an academic tertiary center. The incidence of bariatric surgery is increasing annually. In the year 2016, there's over 200,000 cases of bariatric surgery being performed in the US, which costs between $11,000 to $26,000 per case. There is tremendous potential for cost reduction and quality improvement. Bariatric cases present unique challenges to all team members in regards to difficult airway, challenging IV access, use of specialized stapling device, and synchronized exchange of oral gastric tubing. Because of this unique nature of these procedures, it lends to a team approach. The physician observes that at a tertiary center, there's no consistent team and therefore an increased OR time. We initially hypothesized that the variable OR staff and teaching at an academic center would be associated with a longer case duration when compared to a private hospital with a standardized surgical team. Specifically, we measure the variability of OR staff and the duration of specific phases of OR time in an academic and non-academic center of bariatric surgery performed by a single surgeon and assistant. This is a retrospective study that reviewed all the laparoscopic Roux-en-Y gastric bypass cases performed by a single surgeon and her fellow assistant in 2013 to 2015. We excluded patients with prior bariatric surgeries, revision, and concomitant procedures, as well as cases where OR documentation was missing. This resulted in analysis of 74 cases at the academic center and 106 cases at the community hospital. We looked into the patient demographics, including age, sex, preoperative BMI, and comorbidities. As you can see, the patient cohorts were similar at the two settings. Destination of cases mainly depends on patient preference and insurance coverage, not case complexity. University Hospital is a much bigger hospital with a lot more staff, over 1,000 beds, and community hospital has 139 beds. I think this graph just highlights the very variable OR staff at academic center. The orange bars represent OR personnel at the academic center, and the maroon bars represent those at the community center. The OR staff at the academic center is often 5 to 20 times more than the community center. So now that we've shown the variable OR staff at academic center, we want to know, does it actually take longer to do a laparoscopic Roux-en-Y gastric bypass? This table summarizes the different phases of OR time, and I'll go through each of them one by one. The total OR time is the total amount of time that a patient spends in a room. It takes 15 minutes longer at the academic center, and you can see it trends towards statistical significance. The surgical time was defined as skin incision to application of dressing. Although it appears that it takes longer at the academic center, there was no statistical significance. What we were able to show was the difference in pre- and post-case time between the two sites. The pre-case time was defined as the time patient entering the room to skin incision. It takes 5 minutes longer at the academic center. And the post-case time is the time of case completion to patient leaving the room, and that also was longer at the academic center. This cartoon illustrates that there's a lot more staff members at university hospitals than community hospital. And this is the inherent nature of being in a tertiary academic center. This perhaps explains the difference in the pre and post case time, which is more dependent on OR staff versus the surgeon in the room. We recognize that there are limitations to our studies. The data integrity relies on circulating nurses and anesthesia team keeping accurate OR records, but this wouldn't make a drastic difference in the OR times. Also, the OR turnover time was not analyzed in the study because of the difficulty in extracting data with our system, but perhaps the turnover time was what contributes to the impression that cases at academic center takes longer. That being said, the turnover time is out of control of the surgeon. Although we weren't able to demonstrate a statistical significance between the total OR time, the p-value was close to 0.05. So maybe we'll be able to demonstrate a difference with a larger sample size. This study brings to light the following. There was a high variability in OR staff at tertiary academic center compared to its community affiliate. Although it wasn't statistically significant, there's a trend towards longer OR time at the tertiary center. Perhaps our study was underpowered to show a statistical difference. The surgical case time was consistent in both settings, and it was likely because of a consistent single surgeon and assistant. The greatest variability in time between the two locations is the time in the OR before and after incision. This is likely a reflection of team training. The community affiliate has a more consistent team who's familiar with steps of the procedure, as opposed to the tertiary center where we almost never had the same team for more than a case. The difference in OR time was 15 minutes, and perhaps it's not clinically significant for the patient, but it has this financial impact. If we were to schedule 4 cases a day at the academic center, that would save us 60 minutes, which could be used to schedule an additional procedure. In conclusion, the implication of variability in OR staff can be overcome by the surgeon directing the procedure itself, and an opportunity for improvement is before and after the procedure. Thank you again for the opportunity. I'll take questions.